I think we're good now. We have a good number of people that have just come online. So before I give the floor to Dr. Stylianopoulos, I will just go through a brief information on his biography. And I'm sure all of you know him, but I'll just start with this small introduction. So Dr. Stylianopoulos is an associate professor and head of the Cancer Biophysics Laboratory at the University of Cyprus. He received his PhD in chemical engineering at the University of Minnesota and then proceeded with postdoctoral training at Harvard Medical School. Dr. Stylianopoulos has published over 150 peer-reviewed articles in the fields of cancer research, immunotherapy, and bioengineering. His team has developed novel strategies to remodel the tumor microenvironment in order to improve the efficacy of cancer therapeutics. These strategies have already made it to the clinic through 3 clinical trials. In recognition of his work, Dr. Stylianopoulos has received the YC Fung Early Career Award by the American Society of Mechanical Engineers in 2016 for excellence in bioengineering, as well as awards from the USA Biomedical Engineering Society. He has been the recipient of an ERC Starting grant, an ERC Consolidator grant, and an ERC Advanced grant. He has also secured 3 ERC Proof of Concept grants. He will be talking today about novel biomarkers for predicting tumor response to chemoimmunotherapy. I want to take this opportunity to thank again Dr. Stylianopoulos for accepting the invitation to be part of our lecture series. And I give the floor to him so he can tell us all about his interesting work. Thank you very much.
Yeah, thank you, Maria. Thank you for giving me the opportunity to speak to your society. And it's my pleasure to be here today. So before I start, I would like to disclose that for this topic of my research, the last 3 years, I have filed 3 patents. I have received also grants from the NanoCareer, a Japanese nanotechnology company, and also I have licensed the patents to Materia Therapeutics. So for my research, we try to understand why tumors are hard to treat. And what you can see actually in this image, this is a geography of a murine breast tumor, where you can see the process of angiogenesis on the left, where this is abnormal structure of the vessels. And also you can observe that at the center of the tumor, there are not much vessels. So only by looking at this chaotic structure, you can easily tell why drugs cannot easily get to the tumor, since most of the cases, the drugs will get to the tumor through the vessels. Also, the other comment on this image is that what we see on the center of the tumor as a vascular region is not that vessels don't exist there. Vessels used to be there, but they're not functional. And for that reason, the contrast agent that we use in order to take this angiography image cannot reach the non-functional vessels and goes on to the functional. But the thing is why the vessels in the tumors are not functional. So in many cases, like in desmoplastic tumors, the reason that they're not functional is because they're compressed. So what you see here is this is actually from patients with cancer, histology images, where the arrow shows the position of the tumors, and you can see also the vessels. So in this case, for example, we see that here's the cancer cells, and this is the lumen, the vessel, that we cannot see the lumen because the vessel is totally collapsed. The same also is happening to this image and to this image. While here you can see actually the lumen of the vessel, but it's clear that the lumen is deformed. So in this case, we have compromised blood flow, while in the other 3 cases, there is no blood flow at all. So this vessel compression is actually a hallmark of tumor pathophysiology. And the question is why tumors have compressed vessels. So one of the main reasons that tumors have compressed vessels is that because as the cancer cells grow very fast in the confined space of the host tissue, they start to exert force to each other. And at some point, they grow in this confined space. And at some point, they start to touch the vessel walls. So as they touch the vessel walls, they start to push also the vessels and to compress them. And at some point, as you can see on this movie that we created in order to demonstrate this event, the vessels become totally disabled and non-functional and collapsed. So in this case, there's no flow. So the question then is, why tumors? What's the cause of these collapsed vessels? So the cause of the collapsed vessels is because this mechanical stress is generated inside the tumors. And the question is how we can see this mechanical stress accumulation. So one simple experiment that we started to do, this was about 15 almost years ago, is that we take a tumor, and this 41 mammary carcinoma, we make a cut. You see that the tumor will open up like this. And this is not because of gravity. This is because mechanical forces are already concentrated inside the tumor. And when we make the cut, these forces have the space to release. And the deformation that we see, this opening, is a result of the release of the mechanical forces. And this is even not only in murine tumors, but also in human tumors. So I used to go also to the operation room. And what you see here on the bottom of this slide is a intramuscular myxoma that was taken from a 62-year-old lady at the Massachusetts General Hospital. So you see it's a huge tumor. And after the surgery, I asked the surgeon to make a cut, as you see here, similar to the cut that I used to do to mice. And you see that the swelling of the inner surface and the open up of the outer surface of the tumor. And we use this tumor opening in order to quantify these mechanical stresses. And this is evident of tumors, but and in comparison, you can see, for example, in oranges. For example, if we do the same experiment in oranges and we try to cut an orange, you see that it doesn't open up. It doesn't open up because there are no mechanical forces accumulated, what we call residual stresses. So these residual stresses, it's because of the rapid tumor growth within the confined space of the host tissue. And it's observed in living tissues like tumors and blood vessels. Now, I would like to give an overview about the mechanical microenvironment of tumors and what are the mechanical abnormalities that also hinder the therapies. Then, apart from the vessel compression, as I said, we see that we have the cancer cells that proliferate very fast to compress the vessels. But at the same time, however, it's not only the cancer cells, but also host cells like the fibroblasts. So the fibroblasts, under mechanical compression, they start to overproduce collagen and other external matrix components, like, for example, hyaluronic acid. So the overproduction of collagen and hyaluronate causes the stiffening of the tumor. And tumor stiffening is perhaps the only mechanical aspect that the patient or the doctors can sense or feel. So we have the tumor stiffening of the stiffening of the tumors, the accumulation of the mechanical forces, and at the same time, many vessels in the tumor, so that some vessels might be leaky, maybe hyperpermeable, and this causes the excessive fluid from the vascular to the extravascular space. So this excessive leakage from the vascular to the extravascular space causes an increase in the so-called interstitial fluid pressure, or IFP. So another hallmark of tumor pathophysiology is the interstitial hypertension. So that means that when tumors are, when there's high fluid pressure outside of the tumor, when the drugs try to extravasate, as we see here, there's a high pressure on the top that hinders the transport of the drugs from the vascular to the extravascular space. So we know these mechanical abnormalities, and these mechanical abnormalities have as a result that there's heterogeneous perfusion in tumors. So as we see here in this movie, there might be regions in the tumor where they're highly perfused, as we see here on the left, on the right. We have functional vessels. There's some other regions of the tumor, like as we see here, where the vessel seems to be compressed and there's slow blood flow, and the other regions of the tumors where there's no flow at all. So we have this heterogeneous perfusion, and this is causes barriers to therapy in several ways. First of all, and what you see here is a more detailed structure of the tumor vessels, of the tumor microenvironment, where we see the vessel, the blood vessel, which is, as I said, compressed so that the drugs cannot get into the tumor and they cannot get in the vasculature. We have the fibroblasts, and also you can see the different types of immune cells, like, for example, macrophages or the dendritic cells. So one consequence of the compression of the vessels and the hypoperfusion is that we have limited drug delivery, as we can see here, since the drugs need functional vessels to get to the tumor. Also, hypoperfusion does hypoxia, and hypoxia induces immunosuppression. For example, under hypoxic conditions, for the macrophages, we have two phenotypes that are best studied, THEM1 and THEM2 macrophages. THEM1 is immunosupportive, THEM2 is immunosuppressive. So under hypoxic condition, THEM2 phenotype prevails. Also, for example, for the dendritic cells, in order to be mature, they need to have a lot of oxygen to be well oxygenated tissue. Or even the effector, the CD8 T cells, to become effector T cells and to start to kill effectively the cancer cells, also they need to have sufficient oxygen supply. So that means that under hypoxic conditions, we have also immunosuppression. And the other things that since we have this very dense and stiff extracellular matrix, this matrix is like a physical barrier to immune cell infiltration into the tumor. So as we can try also to illustrate here in this schematic, it's a case in these types of desmoplastic tumors that many of the immune cells, they stay in the periphery of the tumor, using the so-called immune exclusive phenotype. But also, this hypoxia and low pH that is created inside the tumor might fuel tumor progression and might be a barrier to therapy in several other ways. So what we see here, for example, in hypoxia and low pH can induce inflammation, fibrosis, and immunosuppression, as I discussed. It's a resistance to chemotherapy and immunotherapy, which are systemic therapies, but also to radiation therapy, where in the radiation, we need to have also a well-oxygenated tissue. Also, under hypoxic condition, we might have an induction of cancer stem cell phenotype, which is drug resistant. Or it may increase the invasive and metastatic potential of the cancer cells, might have a resistance to apoptosis and autophagy, to switch to anaerobic metabolism. Hypoxia can cause genomic instability and unfolded protein response, and of course, hypoxic condition can induce angiogenesis. So all of these together can fuel tumor progression and prevent therapies. So what is the solution that we propose? The solution we propose is to reprogram this tumor microenvironment from this abnormal to a normalized. So in the normalized tumor microenvironment, we want to open up the vessels in order the drugs and the blood to get into the tumor sufficiently. And this we expect that will restore also not only perfusion, will restore also oxygenation in the tissue, so that this will improve also the immunosupportive microenvironment, not only the delivery of the drugs. And overall, we hypothesized back about 10 years ago that this can improve therapies. And the question now is how we can reprogram this tumor microenvironment. So to reprogram the microenvironment, we start to repurposing common drugs, which we call mechanotherapeutics, because our aim is to alleviate the stiffness and the mechanical force in the tumors. So the first drug that we used was losartan, and losartan is a very common angiotensin receptor blocker, which has been approved worldwide, and it's taken by millions of people as an antihypertensive drug. Other mechanotherapeutics we tested the last years here at the University of Cyprus is tranilase, which is antihistamine and antifibrotic drug, and has been approved in Japan and South Korea. We also use pirfenidone, which has been approved worldwide for the treatment of idiopathic pulmonary fibrosis. We even tried dexamethasone, and we found that low dose of dexamethasone, actually, which is a corticosteroid, can improve treat immunosuppression and improve and turn the microenvironment immunosupportive, which is kind of intuitive. And more recently, we use other drugs, other antihypertensive drugs like bosentan, which is not so potent antihypertensive as losartan. And the last 2 years, we have focused on using ketotifen, which is an antihistamine drug. And at the same time, we collaborate with polymer chemists in order to develop nanoparticles, develop new drugs where we can incorporate this mechanotherapeutic agent in order to improve the pharmacokinetics of the drug, because all of them are small molecules that are clear fast from the blood. Now, I'll show you a few results of this. The most promising, I will say, that have already reached to the clinics. So the first drug that we used, as I said, was losartan, this antihypertensive and angiotensin receptor blocker. So what you see on this picture that goes back about 11 years ago when we published this Nature Communication. This is a murine breast tumor model where you see the matrix with blue and you see with green the vessels. This image was taken with intravital microscopy. And this was before the treatment with losartan. And then we start to provide to the animals, to provide to tumors losartan. And in a dose that didn't have any antihypertensive effects. We also monitor the blood pressure of the animals so that we know it will not go down. And after the losartan treatment, we found that you see the matrix is reduced. We don't want to eliminate the matrix. We want to reduce the matrix, normalize it. And at the same time, we see that blood vessels start to appear again. So that means that the tissue was reperfused. And based on this study, we also found that losartan can improve the chemotherapy in breast and pancreatic tumor models. And also, we performed a retrospective study. Since that time, I used to work at Massachusetts General Hospital, and there are thousands of patients with cancer. So by doing some retrospective studies, we identify which patients that receive treatment in the Massachusetts General Hospital at the same time with the cancer treatment, they may suffering from hypertension, and for that reason, they receive a therapy for that. So what you see here on this table is the different types of cancer. renal carcinoma, non-small cell lung cancer, PDAC, colorectal cancer, gastric cancer. You see here the type of tumors, the therapy that they received, and also here you see the patients that have normal blood pressure, the patients that are hypertensive, and they didn't receive any angiotensin receptor blocker or angiotensin converting enzyme inhibitors, and the patients that were hypertensive, and along with the anti-cancer therapy, they receive also one of these two families of antihypertensive drugs. And if we see, for example, PDAC tumors, which was the tumors of our interest, we can tell that for patients with normal blood pressure that receive the standard of care like gemcitabine, they have an overall survival of 9.5 months. But if the same patients were hypertensive, if the patients were hypertensive and happened to take one of the angiotensin receptor blockers or angiotensin converting enzyme inhibitors, they start to live more. So based on these two, they have a longer overall survival. So based on these preclinical studies and also the retrospective studies from patients that received treatment from the Massachusetts General Hospital, a clinical study was initiated back in 2014, and it was planned to take only 2 years, but it took more because not many patients actually could, we have to exclude many patients that couldn't tolerate losartan because of her antihypertensive properties of the drug. So the results were published in 2019 in JAMA Oncology. I was not involved, of course, in this clinical trial, only the preclinical translation of this work. And it was a single-arm study where the standard of care for patients with locally advanced pancreatic cancer was the use of FOLFIRINOX with chemoradiation therapy. And in this study, they had also the antihypertensive losartan. So these are the results, the early results actually from this study. And we see that adding losartan to FOLFIRINOX and radiation therapy and chemotherapy regimen, the R0 resection, so that these tumors initially were big enough in order to be surgery resected. They will get treatment, and after treatment, more than 50, actually in the final results was about 60% of these patients, they have all the tumor resected without any remnants. This is the R0 resection. While if we compare with previous studies receiving the same treatment, the percentage of these patients, of the patients that were able for R0 resection was less than 30%. So there was a tremendous success at that time because it shows that by just adding this losartan can double actually the percentage of patients that can go for resection that have been also diagnosed with locally advanced pancreatic cancer. But as I said, not many people can take losartan. So here in Cyprus, we use other drugs, as I showed you before, like mechanotherapeutic drugs. And we focused the last years on ketotifen, which is called Zaditen, the commercial name of it. And in collaboration with Dr. Anastasia Konstantinidou here at the Medical School of the University of Cyprus and the back of Cyprus Oncology Center, we initiated this in 2022, in September of 2022, this phase 2 trial for the use of ketotifen to enhance therapy in patients with sarcoma receiving standard chemotherapy, and this is still ongoing study. So I will focus mostly on the preclinical results that led to this study, where we first start to see what's the effect of ketotifen in sarcoma in tumor models. So we used two types of sarcomas. One was fibrosarcoma, the MCA205. The other was osteosarcoma, the K7M2. And the first study was focused on the MCA205, where we tried to find the best ketotifen treatment dose. And you can tell that in mice, we can do more work than we can do in humans. So we can change the dose easily. So we provide different doses, as you can see here, starting from the time where the tumors were actually visible. So when they reach a size of 60 cubic millimeters, and we provide ketotifen daily. And at the same time, we use shortwave elastography. This is an ultrasound method, so it's a non-invasive method, where we can measure the elastic properties, the elastic modulus of the tumors, and this tells you how stiff it is. So if it's close to red, the tissue is stiff. If it's close to yellow, to blue, the tissue it's soft. So we start to monitor every 3 days the stiffness of these tumors with shortwave elastography, and we can tell that from day 7, which is when the study of the treatment with ketotifen started, in 3-4 days, we managed, at least for the higher dose of ketotifen, to see the result, the softening of the tumors. And we keep providing ketotifen, so we kept seeing the softening of the tumors in the following days of the experiment. And so we found from these results that the tumor becomes the softest when we use the 10 milligrams per kilogram ketotifen dose, and we use the same dose also for the osteosarcomas, and we saw that the stiffness of the tumors was could be reduced by the same dose of 10 kilograms per milligram. So we want also to study other effects of ketotifen. So we saw that a first indication, which is non-invasive and very fast, and it's actually in real time with shear-wave elastography, that tumors become softer. But does the theory holds? Does the theory holds that suggests that if we make the tumor softer, then you improve perfusion? So we again with ultrasound, another methodology of ultrasound is called contrast-enhanced ultrasound. This is like an invasive because you have to introduce with IV injection the microbubbles into the mouse or the patients, because this also can be applied to humans. In this case, these are murine tumors. And then with the ultrasound, you can see the microbubbles to wash in and out of the tumor. So what you see here, the light color, these are the microbubbles. In the control, you cannot see much microbubbles because these are hypoperfused. But when we provide ketotifen, you see a lot of microbubbles. So we found the normalized perfused area, which is basically the area of perfused area compared to the total area of the tumor. And we found a significant increase in tumor perfusion from less than 40%, the control, up to close 70%. And at the same time, want to see what's happening with hypoxia, because this is the sequence of events. We make the tumor softer, we improve perfusion, we reduce hypoxia. So to do this, we did it ex vivo. And actually, before we sacrificed the mice, we introduced chemo. And then with immunofluorescence staining, you see the hypoxia staining, it's the pink. And as you can tell, even by seeing these representative images, the less pink is here, the least pink. So that means that, and we can see here from the codification of the data, that the hypoxia fraction goes down for this, let's say, optimal dose of ketotifen. And other effects on the tumor microenvironment that we studied was the fibroblasts. Since ketotifen, we know that affects it programs fibroblasts in order for fibroblasts to stop producing so much collagen and hyaluronate. So we see that with alpha-SMA staining, we stain for the fibroblasts, and K67 for the proliferating cancer-associated fibroblasts. And again, the quantification of the data saw a reduction in the proliferating cancer-associated fibroblasts. We also performed picroseries red staining in order to stain for collagen, and we saw a reduction of the collagen. And perform also immunofluorescence staining to identify hyaluron levels. And even from this representative image, we can tell that the hyaluron levels are less on the 10 milligrams per kilogram study dose, and we can see it here also from the codification of the data. So we see that we program, by providing ketotifen, we program fibroblasts to produce less collagen and hyaluronan, and at the same time, we make the tumor softer, we improve perfusion, we reduce hypoxia. And now the next effect, since we increase the perfusion of the tumors, do the drugs go in better amounts? And if the drugs go in better amounts, we see better treatments. And so we perform a treatment experiment. So we combine ketotifen with chemoimmunotherapy in the same tumor models of osteosarcomas and fibrosarcomas. And we use also the same protocol. So we blood the cells, actually we blood tumor chunks here. And then day 4, as you see here, when the tumors have an average size of about 40 and 70 cubic millimeters, we start the ketotifen treatment. And 3 days later, when the tumors reach a size of about 150 to 100 cubic millimeters, we start the therapy with doxorubicin and also with this immune checkpoint inhibitor, the anti-PD-L1 antibody. And we provide this treatment every 3 days. So we have several groups. For example, we have the control group. We have the group that can receive only ketotifen, only doxorubicin, only the immune checkpoint inhibitor, and the combination groups, ketotifen with doxorubicin, ketotifen with the immune checkpoint inhibitor, doxorubicin with immune checkpoint inhibitor, and the triple therapy. So what we see here on the tumor growth curves is that all the monotherapies, they have no response. I mean, doxorubicin or the immune checkpoint inhibitor by themselves, they cannot improve, they cannot slow down tumor growth. But when we start to combine them with ketotifen, we start to see an effect. For example, here, if you combine ketotifen with anti-PD-L1 antibody, we see that the tumor stops growing. Or the same we can see even when we combine ketotifen with doxorubicin. And for the triple therapy, we see that the reduction in the tumor size that goes back to sizes that are hard to detect. So we see that ketotifen in combination with chemoimmunotherapy can provide a strong anti-tumor effect. And at the same time, we also start to produce some early data from the clinical trial. And the first, let's say, benchmark that we have was in order to see whether ketotifen can reduce stiffness in human tumors. So at that time of when we published this paper in Clinical Cancer Research, we have enrolled 7 patients in the study. Now this number has been increased. So you see the age of the patients, the type of the tumors, the male or female, the gender, and this is the baseline stiffness at the first ultrasound when it was performed for diagnostic purposes. And this is the stiffness at after ketotifen treatment. And you see that some patients didn't receive ketotifen for long. These are the patients that they went for surgery. The tumor could be resected. And the other took the ketotifen for a longer time. There are people that patients that receive the standard of care treatment. So from the 7 patients, we can tell that we can see that in most of the cases, in 5 of the cases, we see a significant reduction in tumor stiffness, which is this case. And only the 2 cases that are received only for a week ketotifen, we couldn't see a significant change in the stiffness of the tumor. But for the clinical study, we use the maximum tolerated dose of ketotifen as was approved. So we then went above the maximum tolerated dose. So since we have seen, and it's now robust and well established, the fact that if you make some tumors softer, tumors that are very stiff, softer, can improve therapeutic effects of chemotherapy or immunotherapy or combination of them, then we start to consider, okay, since we know that, why not to use these markers of stiffness and perfusion like a biomarker predictive of response. So before we start the chemotherapy or any type of therapy, to perform a C-wave elastography or a contrast enhanced ultrasound to measure the stiffness and the perfusion of the tumors, and based on this to predict whether the therapy is going to work or not, so that we can separate patients to responders and non-responders. If therapy goes to work, then they can receive the therapy. If it doesn't work, then we can add, let's say, the mechanotherapeutic treatment and monitor with ultrasound during this mechanotherapeutic treatment the stiffness and perfused state of the tumors in order to decide when the standard of care therapy should be administered. So this is easy, can be done. I mean, we have the technologies there. The technologies there are even for the humans. I mean, we use, even for mice, we use a commercial Philips system, and all the transducers that we use for C-wave elastography, contrast enhanced ultrasound, these are transducers that you can find even if you go to a radiologist, but they can work even for the tumors that we study. So what we did here is that we have several tumors, types like breast tumors, 41NE0, 771, fibrosarcomas, MCA205, and B16F10, which is a melanoma. We blood the tumors orthotopically, and when tumors reach a size of 150 cubic millimeters, we start the treatment with the mechanotherapeutic, and this time we had tranilast. And we actually administer different doses of tranilast, 50, 100, and 200 milligrams per kilogram, and the 200 milligrams per kilogram is like the gold standard. It's the one that we use for the studies. We use lower dose in order to have also differential effects. So after a few days of Losartan treatment, or 4 days of Losartan treatment, we perform a C-wave elastography again and contrast enhanced ultrasound, and we start the administration of the immune checkpoint inhibitor, the anti-PD-L1 antibody, 1 dose every 3 days, 3 doses in total. And what you see here, first of all, these are the tumor growth curves for the 4 different tumor types. And we have the control group, the group that received the immune checkpoint inhibitor, and the group that received the combination of tranilast, different dose of tranilast with an immune checkpoint inhibitor. And so what we see here is that increasing the tranilast dose, we see that the therapeutic effects increase. So we have better treatment. Okay, and this is obvious also in other all tumors, cancer types. Now, when we're monitoring tumor stiffness, you see here, for example, the control group, which is a lot of red, so it's very stiff tumor, and we have also blue, which is like a softer tumor, the tumor that received the highest dose of tranilast. And also here you see at the 3 different days that we perform the elastography measure. This is at the beginning of tranilast, and this is during tranilast treatment. The groups that receive the 100 or the 200 milligrams of kilogram tranilast, which are the last 2 groups, we see a reduction in the stiffness in all tumor types. We don't see so significant in melanomas, but you can see that melanomas, they're not so soft. So we see the major changes they're not so stiff. So we see the major changes in the actually very stiff tumors, like the other 3 cases. And while the tumors that receive the low dose of tranilast or non-tranilast at all, they would see that the stiffness start to increase or to stay the same. And also, when we perform the contrast enhanced ultrasound, we see here that the control group, there's not much perfusion inside the tumors. We cannot see the microbubbles. While when we treat them with tranilast, we can actually see the microbubbles getting into the tumor. We see that means that we have functional vessels. And we quantify the normalized perfusion area. And again, we see that compared to the first data points, as we see, the tumors that receive the 100 or the 200 milligrams per kilogram tranilast, during the treatment, after 3-4 days of tranilast treatment, the perfusion starts to increase significantly and goes up to even 80% from very low, which is from a very low of 2%, which is here. So we can tell that, and with these methods, first of all, we can measure the in vivo and during the mechanotherapeutic treatment perfusion and stiffness. And then what we did was to plot for all tumor types together the elastic modulus as a factor of the normalized perfused area. And you see that it's a correlation, a strong linear correlation. When the elastic modulus goes down, perfusion goes up. And what we plot here, we separated the tumors, the cases, to progressive disease or to stable disease if the tumor doesn't grow because of the immune checkpoint inhibition therapy. And so we plot here the elastic modulus and the normalized perfusion area before, right before the initiation of the immune checkpoint inhibition therapy. And we plot here the partial disease and the stable disease. So what we see here on this map is that for most of the cases, we have a soft tumor and well-perfused tumor. We have a stable disease. But actually, these are low data. These are not so many data and not really safe conclusions. So what we did was to put together all the studies that we performed the last 5-6 years. So we get 1,365 cases and images that were considered. In all of these treatments, as you can see, we follow also the same protocol. So we start the mechanotherapeutic treatment when the tumors had the size of 100 to 150 cubic millimeters. And when the tumors had the size of 250, close to 300 cubic millimeters, we perform an elastography again. And we start the anti-cancer therapy. So we want to see if the elastic properties that we measure here can predict the change in tumor volume. And you see the different cases that we have for the treatment. For example, we have mechanotherapeutic chemotherapy, mechanotherapeutic immunotherapy, chemotherapy alone, immunotherapy with chemotherapeutics, immunotherapy alone, and the triple therapy. For the cell lines, we have different cell lines from breast, pancreatic tumors, breast tumors, sarcoma tumors, and melanomas. Here is the classification of the patients to responders, non-responders, stable disease based on the RECIST criteria that use also for the clinical trials. And these are the 3 types of mechanotherapeutics that we use in these 1,365 cases. So we plot all these cases together. We have the elastic modules and normalized perfusion area before the initiation of the therapy, of the chemoimmunotherapy. And you can see how the classification of the patients to non-response, stable disease, and response changes. And this is a very strong indication that actually elastic modules and perfusion can actually predict the efficacy of the treatment. So this holds not only for the different tumor types separately, as we see here, but even we put all the tumors together. So it seems to be a universal effect, at least for tumors of these characteristics. And apart from that, we thought that since we, in these cases, we use the average value of the elastic modulus, the average value of the stiffness, why not to take it a step further? Since we start to learn also in the lab machine learning and this type of artificial intelligence and image processing methodologies, we perform a methodology taking these elastography images, and we perform a neural convolution analysis, as you see here, with different convolutions of different parts of this image. I'm not going to go into details. So we train the algorithm, this algorithm, in order by reading these elastography images to separate patients or tumors, in this case, responsive, non-responders, and stable. So we have about the 60% of these cases for the training of the algorithm, and we left the remaining in order to make the predictions. And these are the predictions of the machine learning algorithm that we developed. So this is the true label, and this is the predicted by our algorithm label. So what we see here, for example, we have 71 plus 3 responders from the test group, not the trained group. And the algorithm predicted that 71 of these cases as a responder, and the other 3 cases, it missed it because it predicted it was going to be stable. So for the stable tumors, we have 5 in 48 in 9 total cases. The algorithm predicted only for these 48 cases it will be a stable disease. So it means 5 from this case and 9 from this case. And for the non-responders, there are total 69 non-responders in the trained group, in the test group, I'm sorry. And the algorithm predicts that 59 of these would be non-responders, and the 10 were non-responders. The algorithm predicted to be stable. So the success rate was about 87%. But since then, we have made further improvements to the machine learning algorithm, and so we have reached from 87%, now it's about 98%. So this shows promise that the machine learning algorithm we develop can actually works well, at least in preclinical tumor models. And we recently got a co-developed program in collaboration with the German Oncology Center in order to apply this algorithm also to the clinical setting. So our vision is to develop a software like what we have started to develop here, where it's going to read the elastography images and then to make a response to provide probabilities whether this image, based on this image, the patient is going to respond or not to a treatment before the initiation of this therapy. So this is actually what I would like to discuss with you today. I would like to acknowledge my lab members and the collaborators at the Cancer Biophysics Laboratory. We are two PIs, two principal investigators. It's me, and it's also the research professor, Professor Bekris. And we have also the postdoctoral fellows. We are here, lab technicians and PhD students. I would like to acknowledge the collaboration we have with the German Oncology Center at the back of Cyprus Oncology Center. And also outside from Cyprus, we collaborate closely with Rakesh Zain from Hamburg Medical School and Horatio Cabras from the University of Tokyo. And our funding is mostly coming from the European Research Council, but also received funding from Horizon 2020, the Research Innovation Foundation of Cyprus, and also recently we got also a grant from NIH. And this is my lab. So thank you for your attention, and I'm happy to take any question you might have.
Triantafyllos, thank you for this very nice and very informative presentation. So for any of you that has any question, we can just write it down or raise its hand, her hand or his hand, and we can go on in answering it. So so I have one question. I'll take the liberty of asking you the first thing. So actually we have one question from Dr. Konstantinos Zamboglu, so I'll just give the floor to him. So yeah, I think.
Hello.
Hello, Konstantinos, you are online.
Hi, yeah, congratulations, Maria, for the organization, and congratulations to Triantafyllos for the very impressive results and the excellent work you are doing. I have a question. You know, I'm coming from the local therapy field, so surgery, radiotherapy in cancer, and you showed really nicely how you affect the systemic therapies. How much do you think that the modulation of tumor stiffness, extracellular stiffness, also might help the surgeons and the radiation oncologists in their treatment?
So thanks, Jose. First of all, Χρόνια πολλά for your name day. So this is a very nice question, and actually I was thinking also how, because I'm coming from the drug delivery field, let's say. So I see that the treatments like the drug that get into the blood and then extravasate and then goes into the tumor. So this is obvious to me that this kind of treatments can be enhanced, this kind of therapies can be enhanced with the treatments that I propose. But I would like also to see what the effect of these mechanotherapeutic treatments will be like, as you said, in radiation treatment, where with a local treatment. I know that in radiation oncology, you need to have also a well-oxygenated tissue in order to be more effective the therapy. But so I expect based on that we're going to see a benefit. But to what extent we're going to see this benefit, we have to see in practice, either in the preclinical or in the clinical setting.
Okay. So until we get another question, so I'll go on with so I was just curious, in the results you presented, you show how the fibroblasts change their behavior, and you end up with a more soft tissue rather than the initial tumor. Do we know how the rest of the components of the tumor microenvironment shape up after this change? Because I assume that you have changes in other components, especially in the immune component. Do we see any behavioral changes in those?
Yeah, so we see an increase in the infiltration of different immune cell types, mostly CD8. We see a shift in the macrophages from, for the control group, let's say, the M2 prevails. Well, when we provide this mechanotherapy, we see that mechanotherapy, along with immune checkpoint inhibition, we see an increase in the M1. macrophages. In general, we can tell with flow cytometry that there are changes that points towards to immunosupportive microenvironment.
Yeah, you did mention that also with dexamethasone at the beginning, that you had results that were counterintuitive.
And we have problem to get this manuscript published because we propose that we give low dose of dexamethasone and we see an improvement in the immune response. And it was hard for the reviewers to get it, to buy it.
Yeah, I mean, because I assume that because the glucocorticoid receptors, you have the U-shaped relation, so you don't know how they function in that respect. Very, very nice. And so another question, have you evaluated these drugs that you mentioned in other types of tumors, solid tumors, and especially can you predict if they would work in the context of the nervous system tumors?
So we're looking for tumors that are, let's say, stiff. They have abundant collagen. And I mean, the hanging fruit was pancreatic cancer. I mean, we start with pancreatic tumors, and we know that also several types of breast cancers that have these abnormalities, that are highly collagenous tissues. And so we saw sarcomas. We have done this work with hepatocellular carcinomas. And also currently for the last year and a half, we work with colorectal cancers.
So I don't think we have any other questions, but I would like to thank you again. I don't want to take the opportunity of keeping you over there, but it was a very interesting line of work, and I'm sure if you, we are expecting much more promising results from this line of work. I want to thank you again for accepting the invitation of being in the lecture
Yeah, I thank you.
And,
it was my pleasure.
Thank you, everybody, for joining us this afternoon. It was lovely having you. Have a lovely rest of your day. Bye-bye. Thank you.
Bye-bye.